Eicosanoids play a key role in regulation of vasodilation, vasoconstriction, and or platelet aggregation. And so as such, eicosanoids can really be very important in terms of vascular health, regulating vascular health. So we will talk about two important eicosanoids that are produced by two different cell types. Prostacyclin, PGI2, is produced by endothelial cells. Thromboxane A2 is produced by platelets. Both play a key role in the maintenance of vascular health. Importantly, both are produced from a common pathway, which is the cyclooxygenase pathway, by a common enzyme, okay, by COX-1 and or COX-2. So, thromboxanes are produced by platelets. Their main effects is to promote vasoconstriction and platelet aggregation. On the other hand, prostacyclin, PGI2, produced by the endothelium, promoting vasodilation and inhibiting platelet aggregation. So in many ways, there's a tug of war between thromboxane A2 and PGI2, meaning their relative amounts will determine what state the vasculature is in and what state the platelet aggregation is in. So if you have higher amounts of PGI2 relative to thromboxane A2, you will promote vasodilation and you will inhibit platelet aggregation. And the reverse would be true. Higher thromboxane A2 would promote vasoconstriction and platelet aggregation. So many of you might be familiar with the use of aspirin as and at low doses to improve vascular health. And this is how aspirin will affect vascular health. Aspirin will acetylate cyclooxygenases, both isozymes, COX-1 and COX-2. Only COX-1 is shown here, but basically it will have the same effect on both COX enzymes, COX-1 and COX-2, and in doing so, by adding this acetyl group to the active site of cyclooxygenases, it will irreversibly inhibit the enzymes, irreversible inhibition. So that means those enzymes can no longer participate in the synthesis of any prostaglandin or eicosanoid. So here's the effect of aspirin, inhibiting irreversibly cyclooxygenases. In platelets, the outcome of that inhibition is a reduction in thromboxane A2. On the other hand, in endothelial cells, cyclooxygenase is inhibited by aspirin as well. However, the outcome of that is no significant effect on the amount of prostacyclin produced by endothelial cells. So the net effect is that you reduce thromboxane, you keep PGI2 about the same, you have higher amounts of PGI2 relative to thromboxane, you are going to promote vasodilation and inhibit platelet aggregation, and that's the desired outcome of this low aspirin therapy. So you decrease platelet aggregation because of the reduction in thromboxane A2. Prostacyclin synthesis in endothelial cells remains about the same, and therefore you promote vasodilation and inhibition of platelet aggregation. So how does this work really? Importantly, before I explain exactly how it works, I want to remind you that aspirin will inhibit both COX-1 and COX-2 irreversibly. Now, in platelets. Once that COX-1 enzyme is inhibited, because platelets are anuclear, that means they aren't able to synthesize new enzyme, produce new enzyme. The enzyme that is present in the platelets is irreversibly inhibited, and therefore the synthesis of thromboxane in platelet will be decreased. The enzymes that are present in endothelial cells will also be inhibited by aspirin. However, endothelial cells are nucleated and they can recover by producing more COX-1 and COX-2, meaning more enzyme is expressed because they are nuclear, and the newly expressed enzyme that has not been exposed to aspirin can essentially continue to make prostacyclin, so the normal amounts of prostacyclin are produced by endothelial cells. Hence, the balance favors prostacyclin over thromboxane, and that's the net effect of low-dose aspirin on promoting vascular health.